Hello, everyone. Welcome to the American Academy of Child and Adolescent Psychiatry's virtual forum on collaborative and integrated care. My name is Melissa Hopkins, and I'm a child and adolescent psychiatrist at University of California, Davis in Sacramento. And I'm the director of the Pediatric Integrated Behavioral Health Services program here. I'm excited to be one of the presenters today to talk to you in our second session on getting started building your integrated care program. I'll turn it over to my co-presenter to introduce herself.
Hello, I'm Marian Earls. I'm a developmental and behavioral pediatrician and a general pediatrician. I am located in North Carolina and a specialty group. I'm also a clinical professor for UNC Medical School, and I'm the chair of the AAP's Council on Healthy Mental and Emotional Development. We're very focused on the concept of integrated care. So I'm excited to be here today with my friends from ACAP.
Before we jump into our session today, this is just a brief outline of the sessions that are included in this virtual fora. So as a reminder, there are 6 sessions, and this is the second one. Hopefully, you've already had a chance to watch the first session, which is an overview of integrated and collaborative care programs. The goal of this session today is to provide a framework with practical strategies for designing and implementing successful integrated care models. Every clinic has unique characteristics and needs. However, guiding principles are transferable and provide a reliable scaffold to integrated care programs. Now I'm going to turn it over to Marian to review the mental health competencies for pediatrics.
I'm really excited that folks are interested in doing collaborative care with pediatricians. And as a co-author of the Mental Health Competencies for Pediatrics for the American Academy of Pediatrics, I wanted to prepare folks for what are we asking pediatricians to do so that as people enter into these collaborative relationships, they're aware of what are the competencies that we'd like to see integrated into primary care, into specialty care for that matter, so that folks can do this collaboration effectively with mental health professionals. So the mental health competencies are divided into 2 sections, one called clinical skills and the other around practice enhancements. So you can see here the clinical skills are focusing not only on treatment, but begin with primary promotion all the way through early identification and to treatment. Examples of primary promotion in pediatric practices, many of them are doing reach out and read, or they're doing discussions with older kids and adolescents about things that are helpful to promote their healthy social emotional development. So these are the promotion and primary prevention pieces, the assessments. So we're expected to be able to recognize a mental health emergency and know how to respond to that. Pediatricians are expected to be able to diagnose and manage mild to moderate ADHD, anxiety, depression, substance use, and now pediatricians are also being asked to routinely screen for suicidality in kids 12 and up. Treatment, you'll see in this section that there's a focus on fundamental communication skills, such as common factors and common elements to initiate care. But there's also a real emphasis on being able to co-manage and collaborate with mental health specialists, which is certainly pertinent to today's discussion. So these competencies include fundamental communication skills, as I mentioned, the common factors and common elements approaches that are based a lot on motivational interviewing, the capacity to incorporate that content and tools into promotion and primary care, to have some skill in psychosocial assessment with kids who do have mental health conditions, to understand psychosocial therapies and psychopharmacologic therapy, to begin to function as a team member and co-manager with mental health specialists, and to commit to embrace mental health as integral to pediatric care. So we say mental health is health and should be something that's incorporated in all aspects with all patients. So Specifically, I wanted to give some detail about Bright Futures. Folks may have heard about this. Bright Futures gives the guidance for the periodicity schedule for well visits across the age span from 0 to 21. And the recommendation is that routinely with all children, that there's a behavioral, social, emotional screening that happens. Preferably, organized to be done prior to the visit, where we use data collection forms that can be reviewed by the primary care clinician prior to the visit. And so it's recommended that we use age-appropriate validated tools for social, emotional, and mental health function, and then also to elicit social drivers of health using validated questions. Those are not so much validated screening tools, but there are validated questions. And we want that focus to be around child well-being. So that would be household and family social well-being, things like, housing security, food insecurity, that sort of thing, environmental influences, structural racism, and then parent personal and parent-child relationship well-being as well. And the important feature of this recommendation is that screening is always followed by discussion and engagement of the patient and family. And that even if that screen does not show a concern, very often in the course of the conversation, concerns may arise, or there's an opportunity to reinforce strengths and protective factors. And then, of course, collaboration on the plan of care includes that family, so that we're eliciting strengths and protective factors, we're responding to those screens. We also have guidance for folks on how to use secondary targeted screens if that's indicated. And there's a mental health algorithm and table of tools to help folks with that work. So it's just important to understand this is what people are being asked to do, and they are more or less ready to do a lot of these things. There's also some very standard screens that people are expected to do, like developmental screening of young children, perinatal depression screening in the infant visits, and depression and suicidality screening routinely with adolescents, in addition to these general screens at all well visits. So the other part of those competencies, as I mentioned, is practice enhancements. And I've highlighted here the collaborative and consultative relationships because it's absolutely necessary. There's also needs to be a change in the practice team culture. We recommend that people include their front office folks in their processes and understanding what they're doing, and include nursing, other clinical staff and nursing staff. And it's really important for people to understand trauma and resilience informed care as well. It takes some systems change. People have to be prepared for the confidentiality pieces to be able to talk about trauma and resilience informed care. And we recommend that people work on standardized ways that they're going to communicate for co-management, right? If somebody is co-located or integrated in a practice, that facilitates that standardized communication. But if we're also having referral relationships with mental health professionals, a standardized way that we make sure that we're communicating. And then regular data analysis for practice improvement.
Thank you, Marian. It's really helpful to have in the background a sense of what our primary care pediatrics colleagues are expected to be managing, and the goal of having their competencies as we think about these frameworks. And with that, we'll transition to going through the framework that I will be presenting today. This framework is detailed in this paper that this wonderful group published in Academic Psychiatry in February of 2024. And so if you have further questions, you're welcome to refer back to this paper and the references at the end of the presentation. The framework that I'll be taking you through has several phases. We'll be talking about preparation and assessment, and finally design and implementation. So for our first part, we're going to review preparation phase, and we'll be talking about the pre-work necessary to design these programs, identifying stakeholders and getting buy-in, and identifying a mental health champion. Depending on where you are in the process of your program design, you may need to do some pre-work to set up your program for success. The first step is to consider doing a self-reflection to understand your own motivation for doing this work. This will come in handy down the line to ensure that your motivation is aligned with that of the practice that you'll be partnering with. Ask yourself, why do I want to do integrated care? What are my goals? Consider your own interests. Are you interested in improving access to care and population health? Are you excited by interprofessional collaboration and coordination? Maybe you're a passionate medical educator. Or perhaps you are excited about scholarship, research, and quality improvement. What gets you fired up and why do you want to do this? When it comes to choosing a practice partner, consider your potential partner's motivations in building integrated care programs and whether this aligns well with your motivation. Without this, creating shared goals can be a challenge. Ask yourself, why does this clinic want to do integrated care? And are our goals aligned? Consider the clinic's willingness to change and expand capacity to treat youth with mental health concerns. Watch out for practices that are solely motivated to bring mental health care in-house and more akin to an embedded psychiatric outpatient clinic. They may not be as interested in changing the way they're currently managing patients with mental health concerns, and that could become a challenge. Hopefully, after considering these important factors, you'll be able to identify potential shared goals, and that will be the foundation for your program success. The next step is to consider systems level factors that will impact the program, which involves getting to know the institution, organization, or practice that you'll be partnering with. Ask yourself, is this a practice, institution, or organization that will support this model of care? And who are the key players? Consider how much the practice, institution, or organization values mental health treatment for youth. A key piece of this step is to identify the stakeholders and get buy-in from leadership. This will be discussed more in a later session during the forum, but relationships are the currency of success in integrated and collaborative care. And forming relationships really starts at program inception. Consider institutional, organizational, and practice goals and expectations. And identify areas of concern that could become barriers to success down the line, such as financial pressures or leadership turnover. At the end of this step, you will be able to ensure that there is support for your program and identify any potential areas of concern from the start. The next step is to identify a mental health champion in the practice. This is someone who's passionate about youth mental health care and who will help bridge the gap between your team and the primary care clinicians. An effective mental health champion can help align team efforts, increase buy-in for the model, and guide program development. When conflicts arise in the care team, which are inevitable at some point, the mental health champion may be the psychiatrist's first partner in navigating these differences. Furthermore, the mental health champion is the psychiatrist's ally by extending the psychiatrist's reach and keeping mental health care on the forefront of the primary clinician's mind, even when the psychiatrist is not present. To identify a mental health champion, ask yourself, who will be my partner and who is already treating youth with mental health concerns? Consider which providers are the most interested in mental health care and what motivates them. Get to know them and invest in relationships. By the end of this step, you will have identified your mental health champion and begun to form an effective partnership. Okay, we've now gone through the preparation phase and we're going to move on to assessment. We will cover getting to know the clinic and assessing clinic readiness, as well as conducting a primary care clinician needs assessment. The first part of the assessment phase is spending time getting to know the clinic that you'll be partnering with so you can best design the program to be compatible with the specific clinic setting. So get to know the clinic, visit, meet the team, spend time with the providers in the clinic, observe, shadow them. Ask yourself, how do things operate now? And how will my team fit in? How ready is this practice for integrated care? Consider anticipated challenges, such as issues with workflow, space limitations, logistics, and what steps are necessary to be prepared for launch. You also want to evaluate the current culture and practice around screening for, assessing, and managing youth mental health issues. Ask yourself, are there currently workflows in place to screen for youth mental health concerns? How are mental health concerns currently handled, including placing referrals to specialty mental health services now? Consider the level of support that will be needed for the clinic team, and make sure to meet with the clinic team and stakeholders to understand their desired workflows and staffing needs. There are readiness assessment checklists that can be used to help you assess the clinic readiness, and these can be found in the resources provided at the end of this talk. By the end of this step, you're starting to get a sense of the current state of things in the clinic and getting to know the providers and how ready the practice is for collaborative and integrated care. The next step is understanding where the primary care clinicians are currently regarding assessing, managing youth mental health concerns. You want to ask yourself, how much experience do primary care clinicians have with treating mental health concerns in this practice? Where do primary care clinicians need support and what services are needed the most? Based on this, you can consider any anticipated barriers to creating effective change. For example, perhaps the primary care clinicians in your practice don't feel comfortable prescribing stimulants. You may need to do a lot of work to support them and getting them to where you would like them to be, and this may take time. An effective way to assess the primary care clinician's baseline is to conduct a needs assessment. You can survey your primary care clinicians to evaluate their baseline comfort with addressing youth mental health concerns, as well as to assess their knowledge and skill regarding youth mental health treatment. Query your primary care clinicians to understand what they want and need from your services. Meeting them where they are will help increase buy-in. With this information, you'll also be able to establish a baseline for your program and monitor efficacy over time, as well as design targeted educational content for your primary care clinicians to advance their comfort and skill set. At the end of this step, you'll have a good sense of your PCC's skill set and comfort, so you can design clinical services that will support them wherever they are. Okay, we've covered assessment, and now we're going to move on to design and implementation. Before we jump into this phase, we're going to take a moment to review some of the models that were covered in the first session of the virtual forum, just to remind us of some of the options that are out there. Hopefully, this will look familiar. This is the SAMHSA levels of collaboration and integration, and this provides a great visual of the spectrum of models and features their key elements from communication to physical proximity and practice change. Hopefully, you're getting the sense by now, but models really vary vastly in their characteristics. And again, there's no one right model or best model. I cannot emphasize this enough. In fact, models can really be thought of as representing a continuum of approaches, and programs can incorporate several different models that are complementary. This image has been put together by a colleague of mine and captures how we want to be using a population health approach to guide program development and model selection for your specific clinic setting. The top of the triangle here represents those patients who are at risk or who have subclinical mental health presentations. The middle are patients that have mild to moderate mental health concerns, and the bottom represents patients with the most severe mental health presentations. Patients with the most severe mental health concerns are best managed in subspecialty mental health treatment settings and are not ideal patients to be served by a collaborative and integrated care model. They really require more intensive services. Collaborative and integrated care programs best serve patients in the middle and top portions of the triangle. By partnering with outpatient psychiatry clinics and by incorporating different models of collaborative and integrated care into your program, you can serve the whole population of patients seeking mental health services. I'm going to turn it over to Marian to talk briefly about the primary care behavioral health or PCBH model.
I really love that slide that spread all of the various ways that we can be collaborating and communicating with each other. The slide from the spectrum from SAMHSA, and want to reiterate that that's the real importance here is the whole spectrum, and practices may be doing a variety of things. They might have a great referral relationship with someone in the community. They might have someone who's co-located. They may be making great use of their child psychiatry access program for consultation. All of those things can coexist, and it's an important thing to keep in mind that all of those are great ways for us to work collaboratively and enhance what happens for families. I'm going to describe to you this primary care behavioral health model that has been around for a long time. If you're familiar with the Farley Center in Colorado, they've really done a lot of work on this model. And this model is really a team-based approach for managing any kind of social emotional issue that presents in primary care, with the goal of improving primary care overall. So the mental health professional who is integrated in this model is most often a licensed clinician, a LCSW or an LPC, a licensed family counselor who have an interest in working with children across the age span. And it really targets the whole population. As I was describing before, the recommendation is that we're doing promotion for a healthy social emotional development, that we're doing prevention and routine screening, that we're doing early identification. And the great majority of kids who are coming into primary care don't have a DSM-5 diagnosis. They may have functional issues. They may have issues at school where their behavior is not appropriate, but it may not be a DSM-5 diagnosis. It may be very related to the family social drivers of health that they're experiencing, et cetera, et cetera. So with this model, the primary clinician and the mental health professional are working in a team. And it's a very, let's see, high productivity model. And it really is focused on using a warm handoff so that the mental health professional takes a warm handoff in the visit. Usually in this situation, the person is part of the medical home team, and so in the early morning, they may be part of the huddle, and they partner during all the routine visits. So if a screen is concerning, the clinician may manage that themselves, or they may make a warm handoff to their partner to do a little bit more assessment and triage and see whether how significant the concern is. They often routinely see kids with chronic conditions like kids with asthma, diabetes. They often will liaison with the school around kids. They'll liaison with mental health specialists that are outside of the practice and follow and monitor kids. They also help co-manage the more complex kids. As I mentioned, we're expected to be able to manage mild to moderate ADHD and anxiety and depression. The AAP for a long time has had guidance on managing ADHD, so it's expected that folks know how to do that. With a co-located mental health professional, it really assists with that communication with the school and making sure that there's a team-based plan for that patient. So if you look at this content of this slide, so it says the target population is really the entire population from very young children on. Kids generally don't necessarily have a DSM-5 diagnosis, but they may indeed. And as I said, the core principles are those brief interventions. And the billing for this, if you live in a state where they allow you to bill for same-day visits, the billing is usually brief psychotherapy codes and health behavior assessment codes, so that person can bill in the practice as well as the primary care clinician, which is what makes it fiscally possible to do. in a situation where there's an array of mental health professionals who are either in a consultative role or actually co-located and so on, you can imagine how much this enhances the practicability to manage kids from all the way from mild to moderate to more significant and complex conditions where this person can also facilitate that co-management piece. So I'll turn it back to you, Melissa.
Thank you, Marian. And now I'm going to briefly talk about psychiatric consultation and co-management as a model. Many integrated care programs focus on psychiatric consultation, where the child and adolescent psychiatrist supports the primary care clinician in managing common mental health concerns in primary care. When focusing on a consultation model, it's critical to ensure that there are bi-directional communication channels with built-in feedback and that this process is iterative. Okay. This enables the primary care clinician to implement plans collaboratively and with a co-management approach. This is really a care team. Types of psychiatric consultation can range from curbside or informal consultation to electronic consultation to indirect consultation and direct consultation, depending on the clinic setting, patient complexity, and primary care clinician needs. It's worth noting that if you're operating in a separate system from the primary care clinicians that you support, you actually can coordinate care without written consent from a caregiver per HIPAA guidelines, and you can see our resources if you have more questions about that. When successful, psychiatric consultation can help empower the primary care clinician to manage youth mental health concerns. I'd also briefly like to touch on the collaborative care model, or COCM, which is a specific model of integrated care that was developed at the University of Washington Ames Center and has a robust body of evidence to support its use. This model utilizes a patient-centered care team and adheres to core principles of using a population health approach or framework, measurement-based treatment to target, evidence-based treatment, and accountable care to better serve the diverse needs of patients with a holistic approach. In this model, patients benefit from brief and evidence-based intervention to treat their mental health concerns. The team consists of the primary care clinician, psychiatric consultant, and behavioral health care manager, and takes a stepped care approach to ensure that patients who are not responding to treatment are quickly identified and their treatment plans are modified. This model relies on close collaboration and communication between care team members so that patients improve rapidly. Okay, let's return to our framework to talk about our final phase, design and implementation. We're going to review selecting a program model, and we'll cover some additional considerations, including the population health approach and supporting primary care clinicians, as well as touch on longevity. Okay, so now putting together what you've learned through all of the work that you've already done in the prior phases about clinician, practice, and institution and organization motivation, priorities, and readiness, you're now ready to design your program. Remember, there's no one right model, and your program can actually utilize several complementary models to serve the whole population of patients in your clinic. Also, the ideal model may not be where you start, depending on the current state of the practice. In fact, that's probably the norm. Most programs change substantially over time or evolve. And so really, you're choosing a starting point and developing ideas for what may ultimately be a good design long-term, given all the factors that you've already considered. So let's take a closer look. We're going to cover the scope of services, patient selection, workflows for service linkage, metrics, and then some additional factors to consider. So first, you want to consider the scope of services that you would like to offer in your program. Ask yourself, will there be a team member available to the primary clinicians should they need assistance with the patient in real time? And will they offer warm handoffs like in the PCBH model? Will there be case management and service linkage support as part of the program? Will psychotherapy services be offered? And if so, Will you plan for brief intervention or ongoing care? Bear in mind that services quickly fill up without structure. Will you be considering the collaborative care model? What will the role of the psychiatrist be? Will you adhere to a consultation only model or offer short term care and stabilization? Make sure to consider that ongoing care limits the psychiatrist's capacity and patient access. Additionally, consider if you'll prescribe medications. This is frequently requested from primary care clinicians. And if you do prescribe, it can make it more challenging to encourage primary care clinicians to build comfort and skill with psychotropic prescribing. So just bear that in mind. Once you've started to outline the scope of services that you want to offer in your program, you'll be able to get a sense of your team's composition as well. Sometimes this process is done in reverse. You may have a sense of who will be available to be a part of your team from the start and design the services offered around what is feasible. Once you've detailed the scope of services you wish to provide and started to identify your team, you can move on to outlining further program details. Consider how you will ensure appropriate program patient selection. If you recall our population health triangle from earlier, collaborative and integrated care programs, again, are more well suited to support primary care clinicians in treating patients with subclinical, mild, or moderate mental health concerns rather than patients with more severe mental health issues. Okay. Again, those are best served in subspecialty mental health settings. However, your ideas of complexity and severity may differ from that of the primary care clinicians that you work with, and it will take time for them to learn what patients are appropriate for your program and the services that you're going to provide. Investing in a system to triage referrals for severity and complexity will actually help make the most of efficient use of services. And feedback on referrals to primary care clinicians can help them learn more rapidly what patients are a good fit for the program. You may also consider developing inclusion and exclusion criteria as a guide. Okay, we've reviewed the scope of services and patient selection. Let's take a look at a few other key aspects of the program design. No matter how well you design their program, it is inevitable that some patients referred to your team will need more intensive services than you can offer. And having a workflow for service linkage and care coordination will help ensure timely access to care for all patients. Another important aspect of your program design is to define metrics for success. And it can be helpful to plan to use measurement-based care and validated screening tools. This will be discussed more in depth in a later session for the virtual forum. Finally, remember, relationships are key, and it's helpful to build in face-to-face time with your primary care clinicians from the start. Additionally, building in formal and informal educational spaces can help ensure that you support the advancement of your primary care clinician's skill set and knowledge. Once you've settled on a design for your program, it's time to take a step back and examine your plan. Ask yourself, does this model meet the needs of the clinic, address shared goals, and align with my values and that of the practice? Is this the ideal model? Are the roles of care team members clearly defined? If your starting point is not what you would consider to be the ideal state, consider developing a strategic plan to work toward your ideal design over time. This may involve scheduling checkpoints along the way at regular intervals to assess the program's success in meeting agreed upon goals and to develop plans to adjust as you go. At the end of this phase, the desired outcome is to have designed a program that meets primary care clinicians where they are and satisfies the mutually agreed upon goals. There are some additional factors that are worth considering when you're in the design and implementation phase. First, you want to stay true to the guiding principle of using a population health approach. Again, one of the most amazing things about integrated care is its ability to expand access to mental health services by augmenting subspecialty mental health services rather than replacing them. These programs are designed to catch patients with milder presentations, thus freeing up outpatient psychiatry clinics to manage the more severe presentations, thus caring for the whole population. This can be thought of as a form of early intervention. And so, again, early detection with population level screening is important. While it's likely that there will continue to be a shortage of mental health treatment for youth for some time, one of the benefits of integrated care is the potential to expand the workforce of providers treating youth with mental health concerns, again, by forming effective partnerships with primary care. For this to come to fruition, the integrated care psychiatrist must support primary care clinicians in advancing their mental health knowledge and skill set and working toward that competency. Building and teaching is critical, and it may include many different forms, including case-based teaching, case conferences, lectures, or lunch and learns on high-yield topics. Of course, you want to set your program up for success from the start, so it is important to think about longevity at the beginning. Finances will be covered in a separate section of this forum, but it is important to mention that sustainability can be a challenge for a lot of programs. So start thinking about this at program inception. It's also important to plan for ongoing engagement of providers to ensure that the successful partnerships that you work so hard to establish are maintained over time. Meet often and early with your primary care clinicians. Make sure that you are available to them when they need you the most. If your program is a remote or has a remote portion, think about creative ways to build relationships and make yourself available. Finally, it's important to have ongoing conversations with stakeholders and primary care clinicians to ensure that the expectations for the services that you've set up are aligned and to reevaluate program efficacy over time and continue to shape change. Okay, we have gone through the framework from preparation to assessment and design and implementation. I will leave you with a few takeaway points today. First, full implementation of mental health integration into pediatric primary care takes time and multiple iterations. This is a journey. Invest in forming a practice transformation team, which will include stakeholders, primary care clinicians, a mental health champion, and the child and adolescent psychiatrist and mental health team. And finally, use a systematic method to design your program, spending time to create shared goals and expectations. There is not one right design or approach to doing this. Here are our references for you, as well as the resources promised. And with that, we'd like to thank you very much for joining us and hope that you have enjoyed the session.